in chat, let's do our routine of name, role, and organization. And if there's anything that you're hoping to come away with today, enter that in chat as well. And for those people who have kind of a cryptic name, you might want to rename yourselves. And if you need help with that, Maria or Berenice can help you. And so we're going to talk about process mapping today, and you know the drill. We're going to launch a poll. How would you rate your process mapping skills? Like, wow, you just have this nailed. You're expert, intermediate, you know some, but you still have a little bit to learn, or novice, you know what they are, but you haven't actually done process mapping. So while the poll is up, I'm going to move us forward. And we're going to talk about process mapping. After helping clinics process map and holding just complete process mapping workshops since, goodness, 2010. And before that, because my clinic was doing process mapping, we actually had a consultant who helped us with process mapping, and I'll share what the results of that was in a little bit. With process mapping, often it's really important to map your current state. Like, what is it that we're actually doing? And it's really interesting when I work with practices around their current state, it's really, really hard for them to just say, here's how we're doing things, because all kinds of ideas for improvement bubble up, and we'll get like maybe a couple steps in and someone will say, oh, from now on, let's do XYZ. And I have to reel them in and say, okay, so all we're doing now is putting down what the current state is. What do we do now? And then we kind of talk about, well, what are some of the things that we can try to change, those tests of change, those PDSAs, whatever we want to call them. And then we map like what our future state will be. And hopefully that's going to be a whole bunch fewer steps. And what's in a name? So I think getting stuck on what the name is kind of silly, because they essentially all mean the same thing. So we're going to figure out what it is that we're doing. We're going to map what our current state is for a process, whatever it is. Intake for enhanced care management, or ECM. And we'll find areas that we need to improve along the way. So sometimes people call it process mapping, workflow redesign. And just last week, I actually heard a new one. It was process flow mapping. So there's a lot of different terminology that people can use, but basically we're just kind of getting a picture of what it is that we actually do. And just a moment about lean. So lean is kind of a way of looking at things that originated from Toyota. So Toyota, everyone says that lean kind of originated with Toyota, like as their process of putting vehicles together, they would notice there were bottlenecks. And so they wouldn't just kind of put up with the bottleneck, like, the transmission parts were all building up. And you'd see like, why in the world is this like this buildup of transmissions or headlights or whatever? Like, what is the problem? Like, what's wrong with that person? Why are they being so slow? And so they would stop the entire production, and they would figure out, why are we having a bottleneck? And they would look at not like what's wrong with that person. They would look at the system. So remember, day one, I talked about the most important principle of quality improvement, that every system is perfectly designed to get the results that it gets. And so this idea of identifying kind of holdups in the system is really really key to lean methodology and lean healthcare, actually. And if you Google it, like not while you're paying attention to this webinar, of course, but later, it's just look up principles of lean, and there is no end to what you can learn. There's also even a Wikipedia article, but one of the most important, my favorite actually, principle of lean is defining value from the customer perspective. And for our ECM providers and for our community supports providers, really defining value from our patients' perspectives is really important. And I know that all of our community supports providers really do already do that, define value from the customer perspective. Eliminate when possible steps that don't add value. So some of those non-value added steps are documentation, like documenting when it's not actually needed and it doesn't add value. Having people fill out forms where there's information to fill out that aren't necessary, making sure that all the steps in your process are aligned tightly and efficiently, and then have a pull rather than a push of flow or services to avoid having bottlenecks. I always say, hey, do you remember what the room is that people have to stay in while they wait for their office visit in primary care? It's called the waiting room. And so we batch people up in the waiting room. I worked with an OBGYN practice that revamped their entire office. They had a lot of bucks, so it was a $2 million overhaul, but they designed their practice so that there was no waiting room. So people immediately came into the system. They sat down with somebody who would do intake and verify insurance, and then strive for perfection through continuous improvement. You may remember yesterday that mantra of measure, improve, measure. And so whenever you talk about process mapping, anyone worth their muster, really has to kind of touch on the 5 principles of lean because they are essential to process mapping. And the idea of doing process mapping is eliminating waste. So defects, redos, fix-ups, complaints. So like a defect would be something happening in the system where a patient doesn't receive their food or meals, overproduction, doing work that's not requested or needed, waiting, delays, and queues of all types. Oh my gosh, we don't want to queue up our people who need navigation services or housing and say, okay, well, I'll wait till I get 10 of them, and then I'll start working on finding housing for these people. Non-utilized people, unused employee creativity. My best example is primary care, and that is not including reception staff as part of the care team. And also because I lack graphic skills designs, as you may have noticed from my slides, getting those people who are artistic and do have those skills, honestly, is one of the things that I have used at my clinic. Transportation, so multiple handling of steps, needless movement. Inventory, having if you're a food provider and you have a high inventory of a food, for example, that patients just don't like or need. Motion, oh my gosh, searching, looking for people, looking for supplies or equipment, and then extra processing, which happens all the time. So usually inefficiencies will fit into one of these 8 kind of types of waste downtime. So why should we process map? It gives us a picture of the process. It takes the words and it puts it into a picture. We get agreement on the work, who does what. I was doing process mapping with our free clinic, and they were very, very brave. They wanted to map what happened from a patient coming in the door to discharge. And as we started working through it, we realized that, the reception staff were doing the same thing that the MA was doing it. And the MA was like, wait, you're doing that? And that happens when you get everybody at the table and or the wall or the computer screen or the desktop, honestly, wherever you're doing your process mapping, you start kind of working through it and you realize, oh, wow. So, okay, well, maybe we've got 2 people doing that. Standardize the work. Berenice and I were working with, I can't remember if it was a rural health clinic or an FQHC. It was an FQHC. And the physician said, here's what I do with my patients with diabetes. And he was providing amazing care for these individuals with diabetes. And we asked him, do all of your clinicians at the practice provide the same standard of care? And he's like, I have no idea. So we talked to them about kind of standardizing the work, maybe process mapping, and focus on the process, not the people. Just like I mentioned with lean, if something's going wrong, our natural inclination is to turn around and go, all right, who messed up? And we can't assume a process to work and to have high quality and safe processes if we are relying on people to work harder and smarter. So we need a process. At my clinic, we had a very unfortunate event. I've actually in healthcare seen several unfortunate events because there was something that relied on a person doing or not doing something, and there wasn't a standard process. In our case, we did not have a process for when somebody was a no-show who was on at our clinic for blood thinners. And so we had a patient who no-showed, we didn't have a process, nobody followed up with him, and his blood was, I'll say, quote, too thin, and he ended up in the emergency department and had a stroke and died. So, we didn't look around and say, well, whose fault was that? We looked around and we said, how did our process fail? And we didn't have a process in place. And it reveals opportunities to improve. Along the way, you think, oh, well, we think this is going well, but maybe we need to measure it to make sure. And then documenting it for training purposes can be really helpful. So this looks like a really, really busy workflow, right? This is the workflow that the consultant that worked with the clinic that I managed back in, I don't know, probably 2008. And we wanted to map our process for identifying when patients were due for colorectal cancer screening. This was our current state map. It was a mess. And you can see by the yellow kind of sticky boxes that those were different ways that people did things. So we might refer for colonoscopy, and one person would put the order into the electronic health record. Another person would send a letter to the gastroenterologist. Another person would holler over to their nurse, hey, Ellen, get my patient set up for a colonoscopy. And so, we had lots of opportunities to improve. I'm going to show you a few examples of workflows. And I want to say that I love sharing this workflow. This is, it's kind of the font is small, but we can give you the link to this if you want to actually go and look at it because it's online. But this is the Alliance referral chart for ECM and community support services. And this workflow was designed by Ryan Rousseau at the Camden Coalition, who I have to say has mad processing skills. Like, this is a beautiful workflow, and you can see that it's really fairly complicated. And this is like, we don't know what the process is for referring patients through the Alliance. And when we look at this, we can see, wow, it is really complicated. This is a process map that HIP was working with the Population Health Innovation Lab over the last 2 weeks, and that was to identify patients who are experiencing toxic stress and then identify what the referrals are, where we could refer them. And you can see that ECM and community supports are in there, as well as other CalAIM benefits like dyadic therapy, the community health worker benefit, and doula services. And I will zoom in a little bit on the kind of mini side process map on the right-hand side. This is an example of a diabetes protocol where there is a process, there's if this, then that, then what happens. And usually you'll see that for every step, it's kind of a noun, verb, noun, like MA receptionist schedules patient. One of the big mistakes that people make is they say patient is scheduled, but who does it? Like what role does it? So, just be careful about doing your process maps and saying Berenice schedules patients, because, Berenice may not always be with the clinic. So you always want to have the role who does what. There are certain risks of process mapping. You get started and it can just be, well, you saw the Alliance referral process map. And so, it can really drive you a little bit bonkers. So the benefits of process mapping is that you have aha moments. So you think a process goes some way, but then you map the current state and you realize what it really is. You then map your future state, what it should be. And then your future state eventually becomes your current state, and you move on to an even more, let's call it lean process that is very tightly put together. So one of the questions I often get are, okay, so we can go just totally crazy mapping processes. Which processes should we map? And my answer is that if there's anything that needs to be standardized that affects quality, equity, patient safety, and staff safety, cost of care, patient or staff experience, and or efficiency, we should be looking at those. So some examples for ECM and community supports are quality, ensuring that we have timely housing that meets the needs of members, foods and meals that are nutritious and easy to prepare or consume. Like can we map that process out? Or ECM that results in better control of chronic conditions. And I think I heard somebody speaking, and I'm just going to check whether somebody has a question. All right. Equity. I think there's, a chance to, when we map our processes, to make sure that there are not any decisions or actions within our processes that insert inequity or racism without our realizing it. Patient convenience and experience, structured data capture. So ensuring that in your processes, you are documenting data in a way that you can pull them for quality improvement. And one of the ones that I was thinking about, especially, well, either for community supports or for ECM, is A1Cs for patients with diabetes, other labs, weights, well-being. So, if we're providing housing, we hope that somebody's well-being improves. And there are, for example, depression and anxiety assessments that we can administer, and risk management, making sure that you're, documenting everything, you're closing loops, revenue cycle management, of course. So those are some of the examples. So when you're going to be mapping a current state process, you want the right team. So anyone who touches the process. I can't stress that enough. As we were doing that process mapping with the Population Health Innovation Lab, we didn't have our clinics with us. Like we're also supporting 4 clinics in Santa Cruz County, and they were not there. There were steps that we weren't sure how things went. Focus on the process as it is today. Try to name it before you get started to make sure you're all on the same page, and just start walking the process, starting with the first step and mapping it as you go, and make sure that you validate it with peers and other people involved in the process. And you can do low-tech mapping. So just have square sticky notes, rectangular sticky notes, Sharpies, butcher paper, or a flat surface to kind of stick your sticky notes on. Flip chart paper for your parking lot. And then a lot of folks will do process mapping and say, but okay, so we've got it here on the desk, but my computer's over there, and sometimes you need to have clear tape to stick your sticky notes to butcher paper or a large piece of paper. So I'm just going to pause. Bernice, Maria, any comments in chat? Questions?
There are no comments or questions in the chat, Judy, and I don't see anyone's hands up either.
Okay, cool. So I'm hoping that at our in-person October 18th monthly collab meeting, we might be able to work on a little bit of process mapping. And as always, we have offered to do process mapping with you. We worked with the county, so we worked with Lynn Lauritsen to do a little bit of process mapping in real time. Basically, you can just tell us, we want to map this process, and we'll schedule a Zoom call with you, and you tell us what the process is, and we can map it for you. And we use a process mapping software that's free. It's actually pretty popular. Maybe you've heard of Lucidchart. And what's nice about it is that you can share it. So for example, Laura, who's at HIP, and I were working on a process map. Both of us at the same time, we were working on the process map, talking to each other, and we can do the same thing so that you can kind of, if you're not, savvy on process mapping, so that you can kind of learn how to use the software of Lucidchart. When you're doing paper process mapping, it's good to have a facilitator who keeps the team on track. There's always that person who seems to take the team on a tangent, and they say, well, what about this other thing? And if you have a big sticky note that is what you call your parking lot, and you just say, okay, that's a really good point, but we really need to map our current state right now, so we're going to put that on the parking lot. Or people will say something like, gosh, well, don't we have a policy and procedure around that? Put it on the parking lot. So-and-so is going to check whether we have a policy and procedure on, I don't know, translation service or something like that. And the facilitator also asks questions like, what happens next? Do we always do it this way? Does everyone do it the same way, and more? And when you get stuck with, well, sometimes it happens this way, and sometimes it happens that way, just apply the 80% rule. So what happens 80% of the time? And then the recorder has a very important role of writing the steps on the sticky notes and placing it in sequence. And it can be really stressful because the recorder writes the steps and somebody says, no, that's not how we do it. And they crumple up the sticky note and throw it on the floor and start anew. And then you have to kind of place arrows for the flow. But it doesn't have to be high tech. And I have done process mapping on walls, in hallways. I was doing process mapping in Arkansas, and we were working in a hallway, and the owner of the practice walked by and he's like, hey, what are you guys doing? And we said, hey, well, we're mapping test order tracking through to patient receiving the results of the test. And he's like, oh, well, walk me through that. So we kind of walked him through it. He's like, and he walked away. And the next day, their care coordinator called and said, oh, he's gone nuts. He wants to map everything. But yeah, so it doesn't have to be fancy, doesn't have to be any type of specific mapping software. So they tell a story. The kind of ovals are often a start or an end point. Kind of a diamond is a decision point. And so if you have square sticky notes, that can be a decision note put on its corner. And then the rectangular sticky notes are more like action steps. And in general, you keep the flow in one direction. So it kind of looks like this. So if we were to say, this workflow is about connecting a patient to ECM and or community supports. We have words and we have the process map that gives the diagram or the visual. And this actually is something that I think our collaborative should start learning a little bit more about. So for our primary care clinics, some of which we work with on a regular basis, some of which we don't, for example, like some pediatric practices, it would be good for us to know in our primary care clinics, what is your process for connecting patients to ECM and or community support? So we know at the county that most of their referrals for ECM, for their ECM program, come from kind of internally, their clinicians saying, hey, this patient should be in the ECM program. But what about community supports? Like where along the process of a patient's journey at a clinic are they connected with community supports? Is there a time when the clinic assesses social drivers of health and recognizes that a patient is unhoused or has food insecurity or something like that? Like, I don't know what the processes are for that. And I will say actually that CMS, or the Centers for Medicare and Medicaid Services, in the proposed rule that was published in July, and the final rule will be posted in November, is actually kind of doubling down on kind of identifying and documenting those social drivers of health. Or social drivers of health. So in words, I think it would be good for us to know what the process is, because I think maybe ECM is a little more on people's radars, but community supports and connecting patients to community supports and how you do it, I'm just not sure how that goes. And I've been thinking about referrals as well. So if you are a community supports provider, what are the ways that someone can refer? Do you have a handy dandy referral form on your website that you can provide somebody a link and say, well, fill out this form that you can also print? So anyway, process. So process mapping to figure that out is probably a good idea. So the words are, so patient is seen in a clinic and has a need and agrees to enhanced care management or community supports. And then the clinic has to identify, does the patient qualify as a population of focus for ECM? If yes, is it a population of focus that our internal ECM program supports, like the county? If yes, then the care coordinator will refer to the internal ECM program. If no, we'll refer to another ECM program. And the details of that can get a little complicated. You're like, so the question would be like, who is going to go to the Alliance website to fill out the referral? And then our assumption is that if patients are in ECM, that ECM will connect patients with community supports as needed. And then if the patient does not qualify as a population of focus for ECM, we want to make sure that the patient is still connected to community support. So does the patient have housing or food needs? And if yes, then the care coordinator connects to the community support. So the power of the parking lot. The parking lot is also a really good construct in meetings when people come up with really good ideas and you don't want to lose track of it. And so you just say, well, we're going to parking lot that, or we'll take it offline. So designate an area for the parking lot. It can be a piece of flip chart paper, a notebook, shared Google document, and use it as a catchment tool. So while you're process mapping, if there are questions that arise regarding the process, like we have no idea who does that, and we need to find that out. Tasks, who's going to track down the answers to the questions? Who's going to, develop the action plan? So who's going to do what by when? You need to validate the map with the rest of the staff, commit it to Visio or Lucidchart or whatever your process mapping software is. And then capture change ideas. So just make sure kind of the really great ideas that people come up with, make sure those don't derail your discussion about your current state mapping. And then the parking lot can also take care of some of the sidetracks, any discussion or topics outside the mapping that need to be discussed later. All right. So what now? So commit your current state process map using however you do it. Map your future or ideal state after you map your current state. Once your future state becomes your current state, you need to kind of decide, this is how we do things now, better, safer, and more efficiently. And sometimes when you think that you have your future state down and people are actually doing the future state, you need to get data to make sure that things are happening the way you think they are. And I think the issue that gets stuck with me is processes are always changing. So if we have a really keen Visio diagram and we laminate it in a sheet and it's a thing of beauty, it's really hard to change it, to keep track with, as we keep improving. So just kind of think about how you capture that process map, and hopefully it's in a way that is easy peasy. And I'm hoping to show you an easy peasy way in just a couple of minutes, actually. And then use your revised process map to ensure standardization. So we have a process that we rely on. We're not relying on a person to work harder or smarter. Okay. So QI readiness inventory. This will take a couple of minutes, and then we'll check out Lucidchart and maybe even have a discussion if you guys are brave and daring today. So the QI readiness inventory, what I'm going to show you is a very informal on-the-fly assessment of kind of what you might have and what you might need. And this is nothing that you'll find online. This is just as a result of our experience helping practices implement a QI strategy. So one of my colleagues, Dr. Asaf Bitan, always says, leadership is super number one. And so if you want to develop a QI program or have a QI strategy, it's almost impossible to do without engaged, supportive leadership. And think about a QI strategy that is organized. I worked with a practice in Boston, and one of the first things they had so many measures that they were required to kind of track and keep track of, that they just didn't know where to start. And so the first thing that we did was look at between the hospital, because it was a hospital-owned community health center, and the managed care plan, and they were participating in meaningful use, like how many measures are we required to keep track of? And there were over 100. So hopefully nobody has 100 measures. We also worked with the Watsonville Diabetes Center and helped them with their QI strategy. And so just kind of identifying what the measures are, what our baseline is, where we are, what are kind of the tests of change, kind of tracking things over time. Having a dedicated team, a practice improvement team, a PIT team, a QI team, and protecting their time. So when I was the quality coordinator, nobody protected my time, and I was required to come up with all of these reports and look at data, and I needed like 8 hours of protected time. And I wasn't allowed to kind of shut my door and say, put up a do not disturb, so I could work on the reports and the graphs and so on and so forth, but I was constantly interrupted. And so protect people's time. And if you're going to kind of say, hey, you're on the QI team right now, like what can you take away to make sure that they actually have the time to do this work? Make sure that people have the resources and tools that they need. So Visio is great. It's a Microsoft tool. It's kind of the gold standard with process mapping, but it's really expensive and not everybody can afford it. So, find some sort of a tool that you can use for process mapping, for generating run charts, and make sure that people have proficiency in the needed skills, the model for improvement, plan, do, study, act, cycles, reports, run charts, driver diagrams, how to display data so that it tells the story and is easy on the eyes and doesn't include all kinds of extra information. Have your standardized mapped processes for capturing structured data, because if you're not collecting some sort of way to collect data for your quality improvement program, it can be really difficult. I mean, if you're kind of sorting through and trying to gather information from free text in reports or something like that, it just doesn't work. and then identify what your scorecard of measures are and prioritize them. So you may have hopefully you don't have a scorecard of measures that has 100. What those measure specifications are. Just like the Alliance has the care-based initiatives, you know what the measures are, and then they have the very specific specifications of what defines the denominator, what defines the numerator, what the benchmarks are. Make sure you have some sort of reporting capability and reporting structure, share with everyone, and ensure that you have a culture of quality and a language of improvement. And just really quickly, I have 2 more slides to go over. So people always ask me and they say, well, how do we engage staff in quality improvement? And so ensuring, like I've been saying since Monday, that data are for learning in the world of QI, and we are all a team. Find out what matters to them. So when we were working with the Watsonville Health Center, they had a bunch of measures that they had to work on and formalize and build into their quality improvement strategy. And Dr. Violich said, well, we have these 10 measures. And she sent out a survey to staff and said, which are the ones that matter most to you? And they came up with 3 of them. And that's what we worked on. And I loved her approach. Make sure that everybody is speaking the QI language without getting too precious about, we had a conversation with PCG just earlier this morning, like don't get stuck on nomenclature, use language that makes sense. So our discussion this morning with PCG was, if people have no idea what you're talking about and you say tests of change, modify your language and say, what can we try that might make a difference, and build your own QI curriculum, which, if you want to use our slides, if you want us to help you, we're happy to help you gather staff's improvement ideas, but you need to have a strategy for when people come up with ideas that are not good ones, in a way to let folks know, well, we're not actually going to try that right now. It can be a little difficult and hand over ownership. So I would run reports on the team, but then I would hand those reports to the lead nurse or MA on the team. And I'd say, hey, here's your data. When you're done reviewing it with the team, go ahead and post it on the data board and let me know, for this measure and that measure and the other measure, whether there are some PDSAs or tests of change that you would like to run. And then tip sheets for measures can be really helpful as well for staff. Digest the data and present it so it tells the story. In my early days as a quality coordinator, I just put up tables with data in it, and it was just along the lines of digest. It was kind of like a data vomit, and people couldn't digest it at all. They couldn't make heads or tails of it. So present it so it tells a story, like in a run chart, like we discussed yesterday. Share data transparently, including with patients. So as we were working with the Watsonville Health Center, Dr. Violich one day texted me a picture, and she had put their diabetes data in the waiting room. I'm like, oh my gosh, that's amazing. Like, she really doubled down on sharing data transparently. And rotate frontline staff into the QI team so they start kind of learning on as they go. Often you'll get pushback on data validation. And so including somebody who's kind of part of the data can really help. And then if you heard it once, if you heard it twice, if you heard it 3 times, see one, do one, teach one is the best way to learn. And then mentor and schedule one-on-one QI time, carve out time to do the work, because it's just one of those things that just gets put on the back burner as you're dealing with the urgent and important work. And we often call it the tyranny of now. All right. All right, so now that we have taken a really fast run through the model for improvement, process mapping, and starting or building your QI strategy, is anyone gonna do anything in their organization to start applying or doing any of the things that we discussed? Or can you share some of the work that you are personally doing or your organization is doing around quality improvement?
Hi, Judy. This is Lindsay from Front Street. And I'm here with Patrice as well, our Director of Community Services.
Hello.
So we are planning on doing process mapping for at least a few of our procedures. We're thinking we're going to do some work on our end and then contact you actually. So we need to talk about some dates and then reach out. But yeah, we um been experiencing some staff turnover, and so that's something I'm definitely wanting to work on. And I think the process mapping could be helpful, but, along with other strategies. So we're signed up for the TA marketplace and are working on reaching out to Katie Maeda for some additional support around them. But yeah.
Yeah.
Patrice, did you want to?
I was just going to say, I think, Lindsay and I want to sit together. I just got back from being away. This was really helpful, Trudy. I did a little bit of the Lean Sigma thing in Santa Cruz, and this is really bringing back I remember doing the process mapping, but really super, super helpful. It's a little scary because, as you say, you have to dedicate time to be able to do this. And I think that's also even part of like, starting something like this. Okay, who, where, when, how do we make sure we snag that? And I really like the way you laid everything out like, very clearly, what you need, what you have to do, how it best works. So this is really helpful. It's motivating. And yeah, Lindsay and I, we've been talking about doing this, but things come up. We moved and staff turnover, and I was on vacation, and but we will sit together and figure out what we want to process map, do a little just beginning of that, and contact you, and then even further refine, perhaps if need be, as we work with like help with the Tate marketplace piece of things. But it's also very much inspiring me to look at, we do have multiple programs here, not just this one. And it seems like this is really how things are moving forward these days with data, with understanding our services. I've yeah, and just looking at how to do this as efficiently as possible, get familiar with it, bring in the team, kind of reorient to this continuous improvement strategy, and use these tools. So,
Yeah, well said, Patrice. Continuous improvement strategy. So, yeah, I really appreciate that terminology. And, you don't have to be absolutely prepared. We can muddle about, it's okay. And I think that's one of the things that, if you schedule some time with us, we carve out that time for you. And I hope you enjoy working with Katie Maeda. I've heard just the nicest things about her. I know she's worked with the county as well. So I think she knows kind of Santa Cruz County.
yeah. And we've worked with her in another program, so we know her well already. So,
Oh, that's great. That's really great to hear.
yeah.
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 Yeah. So, let's see. Benita, at Modify Health. I know you guys are kind of working on getting feedback from patients as a way for quality improvement, so you can make adjustments.
Yes. Hi, everyone. Yes, we actually have weekly touch points with our CHWs to work with each patient see how they're doing, gather information on just their disease state, if it happens to be blood pressure, if it's diabetes, working with them one-on-one to find out what's going on. So we're collecting and gathering that data. So that's definitely something that we're working to keep refining as well.
Great. Yes, I've used your example that, if you don't have access to SkyO, just asking patients for what is your A1C or whatever, is a great way. Anyone else? I won't pick on anyone, but anyone else, because I don't want to put you on the spot, but anyone else?
I'll share. This is Shelley from the county, and our program, we serve folks experiencing homelessness and serious mental illness, and we currently have SAMHSA funding, and so we are excited to do some process mapping, as we're going to have to change a lot of workflows when our funding changes, and various layers of the program will need to change. So thank you for this opportunity to be reacquainted with these tools. I too had the privilege of attending a Lean Six Sigma training, but it was several years ago. So I feel like this is a really helpful booster shot, and look forward to engaging in process mapping and also just fostering the sort of the culture of QI in terms of, yeah, we want to gather data and test changes, right? Like, is this working? And I appreciate the reminder that data can be very basic. It doesn't have to be complicated, and in fact, it probably shouldn't. If it's a very small workflow kind of change you're testing, then don't get caught up in the machinations of the approach. It really is like, hey, try something out and see how it works. Right? The data is seeing how it works. So thanks.
Okay, so Shelley, I think you could do a mic drop on that. That was perfect and very nicely said. And I know at the county, so Dr. Manu Sarkarati, she is really good at process mapping, by the way.
Good to know.
Yeah, so I think so you guys have Visio, right? So you have access to Visio? Yeah. Yeah, it's really the Cadillac. Lucid Chart has been working, like I remember looking at it back in 2012 and thinking, oh, it is way too clunky. It doesn't even compare to Visio, but over the past 10 years, they've grown in leaps and bounds. I think they've kind of copied Visio. So everything that I used to be able to do in Visio, I can now do in Lucid Chart. And Google is doing away with Jamboard, and they are replacing Jamboard with Lucid Chart, like functionality in Lucid Charts. Like I just do process mapping in Lucid Chart, and Miro, which you can also do for like, strategic planning and things like that. So I will, I am just kind of, before we jump off, I will show you a little bit of what Lucid Chart looks like. And I like it because it's free. So it's available to anyone. All right, so are you seeing my desktop or Lucid Chart?
As you right before you jump into this, Trudy, I just wanted to also say that I really appreciate you reminding us to include the client or patient's perspective into this process. I think that we often kind of forget about that. We have our own ideas of what we need to do and how it needs to work for us and what we're trying to do, but often forget to just like say, hey, how does this work for you? What else would you like to see? Where can we improve in a more strategic way? So I appreciate you just putting that in there as well.
Some of my really brave practices actually get patients to map processes with them.
Yeah.
And get your patient partner or your patient advisory council. So the county has a patient advisory council, pretty sure. So I think all of the health centers have patient advisory councils. So yeah. All right, so hopefully I'm sharing the right screen. Can't tell these days. Will somebody confirm that you're actually seeing Lucid Chart?
Yes, thank you.
Okay. So this is Lucid Chart, and this is actually the map that we did with the county. So it was kind of the enhanced care management ECM outreach engagement process. And it's super duper easy. You just kind of drag and drop things over. If you have a decision, it just kind of pops in. It even puts in a yes or a no. And eventually the program figures out that you're doing yes, no decisions. And you get a pop-up box that says, do you want to make the yeses green and the no's red? And so you just keep typing in if this, then that. So it's pretty quick and easy. And you can do share, and I can share this as a link, and I can allow other people to edit and share it, which makes collaborating really, really nice. And so Laura and I, for example, the program manager on the practice grant, we were able to kind of work in real time. And then when we met with Phil, we were able to add them to it so they could make changes as well. So I think that's all I have for everyone today. If there are any other questions or comments, let me know. We will be, do I actually have one final slide, but I don't need to show it to you. I can just tell you the content on it. So what we will do is we will send the recording and the slides, and we've kept the slides. So yes, it's true. I have very, very modest graphic design skills, but we have purposefully kept the slides very, very plain so that you can take them, make them yours, brand them if you like. We're not proprietary of the material at all. So if you find anything useful over the last 3 days, you just use it. We did this with a health center system in, I think they're in Merced County, Golden Valley Health Center. And we said, here, you can, have these slides. And the person that I was working with took the slides and made them so nice and beautiful and had, pictures in there and made it like really, really engaging. She did a marvelous job, but we will send out all this information in one email. So it'll have the recording, the slides, the resources, and we hope to get that out by end of day, October 9th. And then, just let us know if you'd like any one-on-one sessions or help with anything. We are truly here for you, to work with you. And if we don't have a skill set, we'll let you know. But whether it's proofreading, putting together policies and procedures, process mapping, grant. So we've helped several of our practices with applying for grants. So just please think of us as not extension of your workforce, but just think of us as, so at the county, so Shelley, I'm going to say, think of us as extra help.
That's a good way to put it.
Right?
Flexible.
Yeah. We just let us know if we can help. And if we can't, we'll try to hook you up with somebody else. But we really, truly just don't want to be the facilitator that holds meetings. We want to help you in ways that work for you and to define value from your perspective. And so let us deliver that value. So with that, let's close, and thank you so much. I think my screen just froze.
Before
Yes.
you close, you're talking about extra help. Are we talking about through the end of December, or does that extend like forever and ever? Just curious about that extra help timing, since I feel, have not been able to take advantage of it yet. So is there a time frame here with that?
You should count on through December 31st, 2023. PCG and DHCS is working on 2024. But I'm not going to, I feel hesitant to say anything until things are official and, things are signed on the dotted line. So I think it's safe to, say through December 31st, 2023. But as you know, I mean, HIP is still here. I mean, even when, if the Path Collaborative, we're here. I mean, we do so much in the community that, we're still here for you. And I see a hand raised. Maliha?
Hi, Trudy. I'm Maliha, and I'm a student intern with the Housing for Health Division, Santa Cruz Human Services Department. And I'm new to this process mapping, so I would really appreciate if you provide an input on how I can use process mapping to help the homeless population.
Great. Do you want to set up some time with us to figure that out? We can reach out
Sure.
to you. Okay.
Yes.
All right. So if you put your, so Maria, do we have her email address? Wait.
Let me check.
And if not, I can just put it in the chat.
Okay. That's
Okay.
probably quicker.
Yeah, can you please do that? Thank you.
Yes.
All right. And we can stop the recording.